स्टार्ट कर देना अभी।
आपका तो अपलोड है ना सर?
हाँ,
यही
हाँ, इसमें इन्फो वाला खोल देना।
ये ना।
हाँ। So the topic is very imminent, and what we are going to see the various type of surgery which are available. There is a war of flaps. We are hearing a lot of words, whether we should go for a microcotom LASIK, we should do femto LASIK, whether we should go for a smile or silk, or we could go for contoura, or what. There is an advanced surface ablation. So what to choose? It's become difficult day by day. So we have got a large galaxy of our panelists. They are very expert in their field. We have with us Dr. Monica Jethani. She is very renowned cataract and refractive surgeon from Vadodara. She is director of the eye clinic of Vadodara LASIK Center at Vasnam High Road in Vadodara. She is gold medalist in a prestigious examination DNB, got best paper award in Gujarat Optical Society, even the best video award in MOS. She has conducted various state and national level conferences. She has 6 publication index journal. She is multi-talented woman with dignified personalities and lot of social awards, and she is perfectly a role model. This award was given to her by Women Ophthalmologists Society of the Women Ophthalmological Society worldwide. So with a lot of accolades, she'll be speaking on microcotom LASIK is still the best. Then we have with us Dr. Dhami, who is a consultant cataract surgeon, refractive surgeon at Dhami Eye Care Hospital at Ludhiana. He has presented papers at international conferences, ASCARUS, ISCARUS. He had chaired, judged, and panelist at international conferences of ASCARUS, AIOS. He was awarded Dr. Vinod Arora Oration at the annual conference of Uttarakhand Society of Ophthalmologists. Presently, he is the president of Punjab Ophthalmological Society. He is the past president of IIRSI, has several publications to Indian and international forums. He was first to start phacoemulsification and refractive surgery in Punjab. He is going to speak on femtosecond laser. It's a safer LASIK. Then we had with us Dr. Vavekar. He is a medical director and founder at the Vavekar Eye Institute. He is managing trustee of SIW Charitable Trust, director and principal of Vavekar College of Optometry. He has got decades of expertise, over 30 years of experience in cataract and refractive surgery. He is a pioneer surgeon, Asia's first to perform true bladeless cataract surgery. He was awarded with excellent service in ophthalmology by Mr. Harshvardhan, Union Minister of Health, Government of India in 2017. He got the Best Innovation Award for Vavekar Saurabh Toric Eye Tool in 2019. He won the Gold Medal recognition awarded to exemplary work in ophthalmology at BOA conference in this year. So Dr. Vavekar is going to speak on contour vision for your eyes. Next we have Dr. Anand Parsarthi, is the Chief Surgeon of Center for Sight, Vision and Eye Surgery at Chennai. He had done his fellowship in refractive surgery, cataract and cornea at University of Erlangen and Singapore National Eye Institute. He got the Best Paper Award at American Academy of Ophthalmology in 2007. He got CP Gupta Award in TNOA. He got E.T. Salmon Awards again TNOH for the Best Postgraduate Award. Published over 30 peer-reviewed articles. He is an invited faculty in regular to ASCARUS, APO, WSC, SAO, AIOS, DOS, and BOA. So Dr. Parsarthi is going to speak on Smile All the Way. It's truly yourself. I am director at Navjyoti Hospital at Dehradun. I am past president of IRSI, North Zone Ophthalmological Society. Presently, I am the president of UK SOS. I am also a member of managing committee in 2016 to 16 and continuing it. I published over 30 papers in national and international journals, sub-editor Himalaya Journal of Ophthalmology, and reviewer Indian Journal of Ophthalmology. I won the next Best Paper Award endorsed, presented over 700 papers and keynote addresses, conducted various things, awarded gold medal for IIRSI, awarded IG Honor Award for peer review in 2022, and Dr. BP Kashyap Oration Award at Jharkhand Ophthalmic Society last year, awarded ISCRS Excellence Award for Outstanding Contribution in Refractive Surgery last year, FACO Examiner for this year. With this, I'm going to speak how advanced is the advanced surface ablation. So with this introduction, I would like to invite Dr. Monica Jethani. She is going to present microkeratome LASIK is still the best. Dr. Monica Jethani.
Yeah.
मैम
Uh,
यही है ना इधर इधर इस साइड
इस side? Good morning, one and all. I'm extremely thankful to Vinod Arora sir for including me in this IC. And excuse me. कहाँ है? चालू करो. खोला नहीं था, कुछ और खोला था आपने.
इसमें है आपका?
नहीं है ना?
आपने अपलोड करा है?
हाँ हाँ करा है, आपको बोला भी पोडियम पे. Is microkeratome, LASIK still the best? So with the evolvement in the surgeries going on, even microkeratomes have evolved a lot, and it has reached such a stage that there is no more evolvement going on. So there are loads of microkeratomes available in the market, and we have reached a stage where it has reached a stage of perfection, like linear microkeratomes offering us a planar flap, which initially femto used to offer. So with SBK Moria and ML7, we have advantage of 90 micron and planar flaps with the use of microkeratome. So what is the importance of microkeratome? Old is gold. It has a track record of more than 20 to 25 years. And value for money. We stay in India. India is a country which is socio-economically not very well developed, and also to tell you that LASIK is not covered in insurance companies. Cataracts are covered, but LASIK is not covered if it is less than 7 diopters. So we have to keep this point also into consideration. This is the most important slide. If we take this slide home, I think the purpose of this presentation is solved. Don't reuse the blade. If you use one blade for one patient, I don't think you will land up into complications. And now 90 micron and planar flaps are possible with microkeratome. Buttonhole, we always used to defy saying that buttonholes are a complication. It has become so rare, buttonholes and free flaps are so rare, that when I was going through Google to find out a photo, I was not able to find out a picture of buttonhole on Google. In my career of 13 years, I have never come across a buttonhole. So we just keep saying that buttonhole is a complication of microkeratome LASIK, but as a refractive surgeon, I would like to ask, how many buttonholes we have come across in our life? So now we have comparable results of femto and LASIK, and the wow effect is actually much more with microkeratome LASIK than compared to femto on the next day. And there are certain limitations of SMILE. Till date, we have been talking about SMILE from past 10 years, At that point of time, it was still emerging, and we were saying smile is the best. So till now also there are certain problems associated with smile, like hyperopia, high astigmatism. For low diopters, we have to do flat ad. So we are here trying to minimize the amount of tissue used, and in smile we are trying to add the tissue because you are not able to remove the very thin lenticule. Whatever we say, there is a manual separation needed in femto and smile both. So microkeratome cut is smooth. You can just lift the flap without any second procedure, whereas in smile and femto you have to do manual separation. And whatever we say for microkeratome that there are complications with smile and femto also. There can be retained lenticule in the smile surgery, and there is problem of opaque bubble layer, which now has definitely been minimized with the evolvement in the surgery. There is steep learning curve. So youngsters who are coming in, it's very easy for them to do a microkeratome surgery rather than doing a smile surgery. And so the take home message is old is gold, it is cost effective. We should not reuse the blade just because it is in our hand. With smile and femto we have patient interface, so it's barcoded, we cannot use it. But in LASIK flap, we can use the blade as many times as we want. So that is what is causing the problems and complications, and manual separation is needed. And no buttonholes with newer microkeratomes. 90 micron is possible. Nasal flap is also possible, and it's value for money. So to conclude, I would like to say that pre-operative key is the workup in refractive surgery, and from PRK to microkeratome to femto to smile to silk now, and in some time robotic surgery will come. And we have seen doctors shifting gears so soon from Contura. The people who were advocating Contura have recently shifted to silk, and now they are saying that Contura was needed only for 2 to 5% of patients. So when Contura was needed only for 2 to 5% of patients, were they doing Contura only for 2 to 5% of patients when silk was not there? So I think to conclude, I would like to say that it is you who is important and not the machine. Thank you so much.
Thank you, Dr. Monica, for such deliberation. As far as we are concerned, the cost factor is very important. Number one, I think microkeratome still is there, and every surgeon who is using any instrument, say he is doing a smile, he is using latest femtolasic or anything, or doing advanced surface ablation, we have to have the option of microkeratome, because there is specific condition where microkeratome is superior to all the other techniques. I would say there's not one technique which fits all. Yeah. And it's like you have to choose the patient and its requirement. One factor is the cost. Cost is very minimal in microkeratome. Second, everything is improving. It was earlier ALK, which has become a smile now. Lenticular surgery was quite long there. Sir, PRK has become advanced surface ablation now. Femtolasic is changed to contour LASIK now. So these things are evolving, and everything is going to be there. So I think everything has a role. And with this advancement in microkeratome, we have got now getting planar flaps, we are getting oval flaps, even what we have put work there. So it's almost as comparable to as a good femtolasic. But still, femto has some edges. I think Dr. Dhami will be speaking on that. Dr. Dhami, please.
Good morning. At the onset, thank you, Dr. Vinod, for putting such a simple talk and with an excellent title of War of Flaps. Wherever there's a war, there's a thought, there's a process, and retrospective thinking, what to do, and are we industry driven, are we patient cooperation, and what do we want? We want the best. And you heard that LASIK, what is called as microkeratome LASIK, is not gone. It is still there. It is going to be there. And there are situations where this is the only thing you can do. And I believe what you should know is what you don't know. Understand the complications of microkeratom, and then only see that you can avoid those, and microkeratom becomes the best. For me, femtos LASIK shifting was a pressure, a safety, but before that I wanted to know what all is there in femto LASIK. So that's what I'm going to share with you. Share with you what is femto LASIK, what are the advantages, and really there are some disadvantages too. Femto LASIK was designed to deliver a biomechanically engineered flap, faster procedure, lower energy levels, exceptional flap lift, advanced customization, options, contemporary and ergonomic. Well, this is the theory part. Femtosecond laser emits optical pulses which with a duration to the dominant of femtosecond, and that's what separates the tissue. It's a principle of photo disruption. Laser energy is absorbed by the tissue with the result of plasma formation, and the expansion separates the tissue. But the precision is what we are looking here. Well, why all this research was done? Because we were getting larger treatable stromal bed area, enables creation of small flaps, smaller diameters, customized flaps, move the hinge wherever you like, allow user a wider hinge, and may increase the flap stability. That's the main factor. Using the best part of the cornea to ablate is the first reason to shift to femto LASIK. Then what is the difference between the flap of a microkeratom and a flap by the FS, femtosecond laser, is the inverted cut. It's like a tin which fixes onto the box of your anything, tin fixes, but if you invert it, it doesn't come out. That is the how fixation is much better in femtosecond LASIK. It provides a better wound healing, significantly stronger flap adhesions, virtually effortless flap positioning, and reduces flap gutter complications. The biomechanical strength of the femtosecond flap is better because the way it is cut, the way it is separated. I just want to show this portion of it. See how strongly it will fix, like a tin cap fixes into the tin. That's the major advantage of a femtosecond flap. So what we discussed was an inverted bevel cut, an elliptical flap. You can repeat it, tighter spot separations, and OBL incidence is quite less OBLs observed with advanced femtosecond lasers. And the greatest advantage is it matches the anatomical elliptical shape of the cornea, moves the hinge peripherally. Wherever you want, you can put a hinge, whether horizontal or vertical, to save the tissue and ablation going beyond the area of the flap. Just to show you a small video. That's a superior hinge. Superior hinges are always preferred, whereas in a microkeratom you cannot have this because you have only one choice. And then whenever you have a different astigmatic stage, you can create You can change this hinge site, thereby taking it on the nasal side and creating a larger area wherever you want to treat the astigmatism. So, a better flap thickness predictability, you can change the thickness of the flap, whereas with microkeratome, even with a nitro 90 micron labeled marked blade will not give you a 90 micron definite flap thickness. The flap thickness can vary in that from 110 to 120. What in femtosecond flap, it is definitely within 10 microns change. The visual acuity is better. The variation of IOP during creating a flap in a microkeratome is much more. There are expected to be lesser dry eyes. The visual rehabilitation is fast. Now, before you learn a procedure, you should learn what complications you're going to face and what problems are really going to be created. That's where I started. It is better to know what you don't know, and the most important factor in this is docking. A good docking, it influences the treatment, patient counseling, patient and laser handling, patient treatment planning, well-trained surgeon before you commit to surgery, good sterilization and surgeon skills. The steps in femtosecond involve a topical anesthesia, docking, corneal flap creations, and excimer laser. See, for docking, a small video, it's very important to place the position of the nose, the face of the patient correctly, because you will be avoiding the loss of suction, which is what you fear. That's a little showing of how we really create a flap. The docking is the first step. Achha. That's showing the flap creation. Now, complications, improper setting and calibration, inadequate training, improper device, wrong. Let's look at the complications. Decentered flaps, suction loss, uncut areas, dense opaque bubbles, flap tearing, and anterior chamber bubble. Let's take them one by one. This is femtosecond is not short of complications. You have a decentered flap, causes nervous patient, loose conjunctiva, squeezing of the eyes. You got to counsel the patient, and depends on the stage at which suction loss occurs. You can manage the suction loss. That's a small 1-minute video to show you the suction loss and how we manage it. You have to be careful. If you talk of complication-free surgery, it is impossible, because that's the only thing if you don't do it. But in this, you can replace you can repeat the flap making on the same stage. That's the biggest advantage of femtosecond laser. Opaque bubble layer, it causes a high laser energy, wrong canal placements, big diameters, but it can be avoided by taking care of the energy. Showing you the opaque bubble layer. See, whenever there's a tight fitting of the PI, these bubbles, they do take some time to get absorbed, so you have to wait between flap lifting and doing the excimer. Basically, the causes are fluid in between the interface, multiple Dowling scars on the cornea. I have to go fast, I can skip it. Anterior chamber bubbles, I'll show you the video only. This is what is the worst when a bubble comes into the anterior chamber. Then either you postpone or you take off the tracker because it will not track with the bubble in the anterior chamber. Vertical gas means thin flaps, scarred corneas can have a gas leaking vertically. We look onto the video because of there is a short of time. A normal docking, a good patient, cooperative patient, but suddenly you will see these two bubbles? There's the vertical gas leaking and there's virtually a perforation in the flap. You can continue with the surgery. Postoperative complications are not riddled through a rainbow glare, DLK and epithelial. This is most common because you are ablating a surface which has been separated and dissected. And then one surface you don't touch, that is the undersurface of the flap. DLK common but can be treated. Epithelial ingrowths are because of excessive maleflations. We have to avoid it. And flap stria, the most annoying and dissatisfying last complication where there are stria on a thin flap, but these are treatable. So the safety is accompanied with complications and careful treatments, and a pre-thought about it is very important. And believe in yourself, whatever you're best with, whether microkeratome or femtosecond laser, go ahead. Thank you. Thank you.
Excellent, Dr. Dhami. You made a. Please be there, Dr. Dhami. So I think Dr. Dhami has made a point. Femtolasic makes the thing much easier. You can customize the treatment. You can customize the flap. You can choose the hinge. You can choose the thickness. You can choose the side angles. That makes the life much easier. And of course, the microkeratome has been very good, but it has certain limitation. I think the biggest indication for microkeratome is if you get corneal opacity there, where the femto can't work well, if you got some other scarring or irregular cornea, microkeratome is a better option, these things. Second, microkeratome is the cheaper option. Third, it's little less painful. Because we are using energy in the femto, so you have to. So I think both the things have role in our surgical armamentarium, and we will be discussing further. And moving to the next talk by Dr. Wavekar. I just already told you, he's the medical director and founder at Wavekar Institute. Dr. Wavekar, please. Meanwhile, Dr. Anand, you will be ready with you after the session? Okay. So we are hearing a lot of things like smile, silk, and it's very, very confusing to many of us. So Dr. Wavekar is going to clear the myth about contour vision, how effective it is, how good it is. Dr. Wavekar, please.
Do you have a pointer? Pointer है क्या? Thank you everybody, and thank you Dr. Vinod Arora for giving me this opportunity to be a part of a very good instruction course. I am going to talk on contour, no financial interest. Now we started LASIK in 1990 early, and there were a lot of problems like this. And people started thinking, what is the problem? So there were problem was in the excessive amount of higher order aberrations. There were two reasons basically. Number one is those which are pre-existing and the one which are induced by laser. For the ones which are induced by laser, so many things happened, improvement in flap creation, laser machines and ablation pattern. Whereas in pre-existing treatment, we had wavefront guided, then FCAT, and topo guided. But soon it was realized that wavefront guided is only for around 5 to 10% of the patient, because actually people do not have that higher aberrations. FCAT now, it is restricted to presbyopic correction, and topo guided was mainly looked at as a reparative process whenever there is something has gone wrong. So what is the problem with topo guided? The number one is that getting reliable and reproducible reading was very, very difficult. So, and therefore we used to struggle with the kind of treatment we want to give. Now we have Vario, the machine which gives us very, very accurate reading. We'll come to this in ahead. Second is inability to estimate the refractive effect. Now just imagine that on one side 15 microns are getting corrected, ablated, on the other side 13, in the superior part 12 and 19. So you don't know what the refractive effect is, and therefore we used to get a struggle with this. Now we have got proper mathematical robust calculation, calculating nomograms, and therefore it is possible to predict the results. So basically Contura is topo guided, but in new avatar. What are its unique features? Number one is that it treats HOA as well as refractive error. Number two is that the treatment is centered on the corneal apex. Number three, it does aspheric treatment also, so takes care of the Q value and cyclotorsion, and shorter ablation time because it treats cylinder and sphere simultaneously. So what is the benefit? Patient has excellent quality of vision. Somebody has to start doing Contura to believe in the result. All these things are the past. And this is what the FDA results said, that you look at this, 34% of the patient achieving vision better than 12.5, and 65 are better than 2016, and so on. And the same result explain that there are hardly any side effects. Now, but we will not, get proper result unless we have done proper pre-op workup and proper calculation. There are no shortcuts here. So the workflow is like this, that first the readings are taken on Vario machine, and then they are sent to the workstation, and then to the ablation machine. We need to capture high quality measurements, and therefore dryness, position of the patient, position of the ideal image, how to do, nose comes in between, and capture 8 high quality image. Now this is what the thing is, that you can see the two red, see, one is a preferred and second is R is registered. And then these three, optical zone 6.5, 100% data. And then this is a valid for registration. All these things are important. It is also important to look at this map properly to understand lot of finer things which I cannot explain now. So 4 high quality image, scans with best tear film. So we have to take the reading before the tear film starts breaking up. And therefore it is very essential to understand what is the Tibet of the patient. And reproducibility by understanding the differences not more than 0.75, and P and R I have explained. Now this is what I was talking about, reproducibility, that these are the 4 maps, and this one on the side is the difference map. So this is the difference between C and D. You can see C and D is highlighted, and you see the central pupillary area. If the difference is more than 0.75, these 2 maps are not matching. Now to be more critical, we prefer 0.5 only. Alcon guidelines are 0.75, but we go by 0.5 guidelines, and believe me that with repeated training and insisting on quality, it is possible. You get at least 4 such maps. So these 4 maps are sent to the planning station. So up till now we were at Vario, now we go to the second stage, and all these things are checked. K values, axis, Q values, pupil size, and MAD. So I'm sorry, I have to turn around. So you check that it is a raw sedal data, Q value, MAD, that is what is the difference, and the pupil size and the axis. All of these should be matching. Also look at the star. This is the reading which is going to be used primarily for registration, and the pupil should not be too off. It has to be somewhere in between. Once you start taking all these precautions, you start doing well. Then comes the adjustment. What we have to do is that we have to put 0 in the refraction. Whatever map is left, it is treating only higher order aberrations. We have to understand what is the refractive effect of higher order aberrations. And once done that, then you take care of the cylinder and then you take care of the sphere, ensuring that the spherical equivalent is constant. Now, in this, you see that first thing what I am going to see is I have put 0 here. So this is only a map of higher order aberrations. Now, you can see that the difference here between the central and the peripheral ablation is only 3 microns. This is acceptable. The difference has to be 3 microns. Or you can click on Zernike and C4, C12 compensation. Whatever is the value of C12, 2/3 of that, if you add here, you will get C4, and C4, C12 will be equal. They should be of opposite sign. Most of the times you have to feed minus because you know aberrations are in the periphery. Now once that, we need to check the axis, where the axes are matching, and then if required you reduce the optical zone. Okay. Once done that, you take care of the cylinder. There are different rules. If the cylinder is less, what to do, cylinder is more, what to do, and then you adjust the sphere in such a way that the spherical equivalent is constant. Once you do that, it looks very complicated, but you do 20 cases and you will be a champion. This is the Alcon nomogram. I will not go into detail, but I will show you by examples. Again, at the time of ablation, it is very important to follow all the rules. Patient positioning is important. If the patient's head is lying underneath the machine, but his legs are on one side, he is going to get cyclotorsion. We don't understand these points, but so that is important. There are red crosshairs which we keep and see that both the eyes are aligned along the horizontal red hair. And therefore, registration has to be done. Registration can be bypassed, but it is not a good idea to bypass because it takes care of cyclotorsion. Now imagine that somebody has got a aberration like this, and because of cyclotorsion, instead of treating like this, you treat like this. What is going to happen? You are not going to get a good result. So registration is a must. And the benefit over wavefront optimized LASIK is that you have to compensate for angle kappa manually 75%, which is arbitrary. Over here, it is absolutely in whatever microns. And then the pupil size at the time of registration and at the time of treatment has to be same. Because you know that as the pupil changes size, its center shifts. And therefore, we want, wherever the registration happens, we want the center to be over there only. So you register first, remove the flap, take amount illumination to the exactly same level, and then fire, and believe me, you will get a good result. It is also important to check whether the patient was fixing properly. Now this is a reasonably good fixation. If the fixation is poor, we will get good result, but the recovery will be slow. So somehow I have come to believe that if the patient is 6/6 on day 1, that means it's a good LASIK, very, very well done LASIK. If the patient is not 6/6 on day 1, eventually within 4, 5, 8 days, patient will become 6/6, but body is adjusting. It is not a perfect LASIK. So now suppose you, in first case, you did not get a good fixation, then with a device, you can fixate the eye so that you will get a good thing. Now let us see some of the examples. I can stop whenever we want. Now we have a situation here where you can see this is 7 and 3. So difference of 4. So that is not acceptable. So I will have to enter something here. I entered minus 0.10. The difference had become now 3, acceptable. Then we concentrate on the cylinder. If the subjective cylinder is more, enter as it is. The difference between the axis is not significant. Very good. So I will enter minus 1. And this 0.1 will be added to 4.5. So our treatment will be 4.6 minus 1, 30 degrees. It is always the subjective axis we are going to pay. Now the subjective cylinder is same as calculator cylinder. This is one of the simplest cases to do. You can see, but the difference over is 10 and 5. So I'll have to add something here to compensate for the refractive effect of the higher order aberration treatment. So 0.15, and then 1.5 will be here, 3.5. So this will become 3.65. So 3.65, 1.5, and so on. Now we have an example where the subjective refraction has no cylinder. Sometimes you get a situation where there is no cylinder, but the calculated or the higher order aberration is showing a cylinder. Now you look at the map. Obviously one treatment is getting here. Obviously this is inducing some cylinder, and that is why that cylinder. Respect this cylinder. We cannot ignore this. Once you start respecting, you will get a good result. So first I entered minus 0.1 here because there was a difference down below. Half of that I entered here, and half of this in opposite direction. So I will have to, instead of 38, I will have to add 19 here. So it will be plus 9. So 3.25 plus 0.09, the treatment will be 3.16. You go like this is Alcon nomogram, and it works very well. Now there are some cases where contour is not recommended. You are not getting good maps, and there is too much of difference between the axis of the cylinder, and there are many examples. Keratoconus, what we do is that we become liberal about this, MAD and axis and all this, and we just put 0 here and treat, only ensuring that your treatment does not cross 40 microns. So over here, I am treating only higher order aberrations. I am not worried about the, refractive error. Now, Forsythia is, it is not legal, but unfortunately, it works fantastic. There are some cases where calculation in contour becomes a headache. This is the time Forsythia is like, cakewalk. So it is an analytic engine. It improves accuracy of topo-guided LASIK. What it does is that it identifies 3 prominent, talus. We call this talus, and their mathematical effect. And it comes in this shape, in this form, tabulated form. And there are 4 basically origins of cylinder in the eye: anterior corneal, that is K reading; topographic, that is what you are seeing here; posterior corneal astigmatism, and internal astigmatism. Sorry. So it has studied the the taluses and given the refractive effect properly. And the outcome comes like this. All the 4 cylinders are represented, and what is the recommended treatment? You just feed it in your examer laser and fire, you will get a beautiful result. So it is more advanced than a simple nomogram. It is much faster. It takes only 10 seconds and a better post-operative result than other methods, meaning the Alcon nomogram. But in cases where Alcon nomogram sounds dubious. Thank you very much.
Very nice, sir. This the contour vision is centered on the pupil, or
It is centered on the corneal vortex.
vortex? What is vortex? Just to perform.
So basically, there are 3 points we have to consider. One is the center of the geometric center of the cornea, that is the corneal vortex, and pupil center, and the line of sight where it intersects the cornea. These are the 3 points. Over here, angle kappa, everything is not important because it is just centering its treatment on the corneal vortex. That is because our topo readings are taken on corneal vortex. But it has an added advantage. We don't have to bother about adjustment of angle kappa.
And second, would you recommend contour for most of the cases?
Yeah, sir. Yeah. So there are some cases where contour is not advised. If you are not getting good maps, or if the difference in the axis of the cylinder, calculated and manifest cylinder, is quite a lot. If aberrations are very high, that means sometimes you get 19 microns of ablation. So I would better not play with that. I'll just do wavefront optimize. However, our confidence is increasing, so we are doing more and more cases to contour.
That means routinely you are doing most of the cases.
Yeah, around 98%.
And secondly, Alcon is coming with Wavelight Plus. That will be the combination of topo guided plus wavefront. Do you think it will improve the results further?
I had I was fortunate to see their Innovoice machine when we had gone for ASCRS, and the way that engineer explained, it looked like there is a significant jump over Contura. However, looking at a cake and eating is different.
That's right. See, wavefront ablation, if you leave the cornea, they are very minimal. Hardly occurs in 3 to 4% of person. Most of the ablations are limited to cornea. But of course, that will add further to it, further refine the things. Thank you very much.
Yeah, there's one more point I wanted to say is that Contura works far better in advanced surface ablation. The results are even better than LASIK. So, we are very eager to listen to you.
Thank you. Then we move to the next talk. Please.
How much difference between center and periphery on for cities is tolerable or acceptable to go ahead with treatment?
Actually,
You said something about total abrasions. If
yeah,
they're more
see,
than
most of the times, whenever there is too much of ablation, of hair abrasion, the central is very minimal, 3, 5, maximum 7. But the peripheral is like 19, 21. That is the time I am jittery about doing Contura. So I don't even go to for cities.
okay.
Thank you. And our next speaker is Dr. Anand Parsarthi. Already introduced to him. He's from the Center for Vision and Eye Surgery from Chennai. Dr. Anand Parsarthi is going to speak on Smile All the Way. It's basically on lenticular surgery.
Thank you so much, Dr. Vinod. No financial interest, but it would be nice to have some. So, basically, when you look at biomechanical stability, we know the anterior 2/3 is an important part, and that's the reason that Smile has better outcomes in dry eyes, and that has been proven by confocal microscopy. There are of course some disadvantages. One is basically the cost factor, the technical difficulty, and until the energy is optimized, usually the recovery tends to be slower. There are some disadvantages, which is basically the cyclotorsional compensation, which requires a manual correction. I will skip this because it may not be relevant. In terms of choice of preoperative workup, we find that anything between minus 0.5 to about 5 sil works. A good cycloplegic refraction may be a good idea, and you follow it up with a confirmative subjective refraction. The broad outlines for fitness for Smile are the same that you would have for LASIK or for femto-LASIK. Now, there is some settings for standard mode and fast mode, and the energy settings can be put between 150 nanojoules, so 120 to about 180 nanojoules. These are, if you are actually starting off, this is something that you would probably need to check before you actually start the procedure. The good idea would be to start with standard energy settings and gradually lower the energy settings, because that we find helps in faster visual recovery. There are 3 cone sizes based on the white to white, which is small, medium and large. And for our cornea, the small works majority of the time. Just before the procedure, useful to brief the patient so that they understand that what they're going to get. The amount of pressure that a patient faces is significantly less, and always, sometimes even like for femto-LASIK, you got to make sure that the nose doesn't come in the way. Once the blinking dot, basically the fixation light is green in this, the laser application takes 22 seconds with the older machine, the newer one is about 8 seconds. The drying the surface is probably the most crucial step. It needs to be just moist. If it's too dry, you will end up with a lot of black spots. Just a short procedure, how you make sure that you dry the procedure, you make sure you go to the phoneses, dry it, and then just wipe the cornea in the upper and lower part, so that you do not have a very wet or a very dry surface, but err on the side of wet, because that works much better than being too dry. Usually this get the thing. Now this is to dry a surface, so you will have difficulty in the dissection. So this is important to identify pre-operatively or during the procedure itself. This is a perfect laser pattern where a uniform size of the bubbles and the dissection tends to be a lot better. Docking is important. Opt for a soft dock, that means you don't go and bump on the cornea, and usually activate suction at 70% of the applanation. Check for the pupil centration, and if pupil is not centered, you need to adjust. This is an important part of the procedure. Make sure the whole the ablation part is centered on the pupil. It may be slightly nasally decentered, it is not a problem. So this is what we mean by a soft dock. So you just make the patient fixate on the blinking green light, you touch and activate the suction, and the procedure then proceeds. This is how you want it perfectly. The dissection is good, the energy pattern is very good. The lenticular dissection technique, remember this is the outer and the inner circle, and the difference is about 0.5. So this is important because this is where most starting surgeons tend to have difficulty. So first you open the superior pocket, then you go to the inferior pocket. So that's how it needs to be done, and you stay within the cap. Just a short video on how that is, what I mean by that. So this is the bubble pattern, a few slightly dense bubble pattern. Open the pocket, go inside, superior one first, and do the dissection on both sides. Then you go to the inferior part, so you start at the edge and then switch the instrument and then complete the anterior dissection. So here we have already completed the dissection of one part. Now we are going to go for the lower part. Now once you've got the plane both anterior and posterior, you use your instrument, complete the anterior first. Remember, in SMILE, you do the anterior part first, and you can take your time and do it very gently. Of course, slightly easier if you're a corneal surgeon because you get a feel of the cornea earlier itself. And go to the edge, the whole edge of the cap. And now you got to go do the posterior dissection. So if you happen to do the inferior dissection first, the whole cap gets stuck, then you will have more of a problem of dissecting the cap. So this is how you go under. Now you've already created the pocket, you go under, so the feel is different. If you have not got the cap, you got to feel a bit of resistance when you're doing the inferior part. You don't need to do the complete dissection. Same thing, be lot more gentle over the pupil, because that's where the important part is. If you're not gentle over the pupil, you will have abrasions, there'll be irregular surface. The edge dissection is important, so I don't do a complete edge dissection. So once the central part is complete, move the lenticule at 1 o'clock. Then you start separating the edge. So move from 1 to 5 before you complete the whole dissection of the procedure. So here you go on one side, so 1 to 5, about 5 clock hours. Now you got an attachment on the lateral side. So you leave a bit of edge there, and so that you have an attached edge. So this is what we call a central island. So this helps you prevent the rolling up of the SMILE lenticule. So you go to the edge, go around. So now you got a central island, you got dissection on this side and that side, and now your SMILE procedure is almost complete. This is the last part, which is the lenticle extraction. You complete the whole part, all the attachments. So you remove the central island, you go to the edge, and now the dissection of both the anterior and posterior surfaces is done. And now you go ahead with your forceps, ask the patient to look down, pull it away from you first, and then pull it out. Now I've broken it down so that the whole procedure can be shown, but if you do it stepwise, usually doesn't take more than 2 to 4 minutes. This is also just to show a docking, so it needs to be a very soft dock, so that when you're applying, this is almost perfect. So try and do it at one shot itself, and that really helps the outcome. You got to see a bit of lint here, so this needs to be stopped, taken out, and if it's not in the ablation area, it is okay. There are some complications like suction loss, black spots, lamellar dissection, folded over lenticule, torn and retained segments. I'll probably skip through that. If you have time, I could probably just show only the suction loss. So The suction loss is slightly different from a femto because here the amount of patient effort to leave the suction is very, very less. It is actually hardly, if the patient blinks very tightly also the suction, because the amount of suction required in the smile is very, very less. So you have to keep speaking to the patient, and you can see the bubbles coming around. The patient is moving, patient uncooperative. You would need to redock and then go. So depends on what stage of the procedure you lose the suction. You can redock if it's early, and you can recut if it's early. Since we have Dr. Vinod, how much time do we have?
Almost over.
Okay. All right. I'll then leave it at this. In case there is any questions about the procedure, we can discuss it more.
So how much amount the pressure is there? You say it's very, very less. It must be as good as femto.
Slightly less, 20 to 25 is what I was told.
Yeah.
It can go up to 40 depending on how you can adjust the amount of.
Basically, until the cornea is flattened, you can't do it. So there should be proper.
That is the difference between the femto. Femto needs to applanate and flatten.
Yeah.
This has a curved interface.
That makes
Yes.
things.
So you don't need that much of suction. So cornea is in a natural physiological position.
And how do you ensure that the perfect centering is there in all cases?
So we center on the pupil. There is nothing else.
Nothing.
You center on the pupil, you're done.
Any questions?
Thank you, Dr. Anand, for a very, very nice presentation. Especially, breaking the video into multiple parts. That is really helpful. Now we go to the last speaker of our course, Dr. Vinod Arora, and he requires no introduction. He's going to talk on advanced surface ablation. Gone are those days when we were worried about pain and haze and all the complications of surface ablation, because surface ablation has come a long way. And let us hear from Dr. Arora what is the magic.
So basically the things don't die, they come in other forms, and we have got the old neglected PRK back to in the main surgery. So we evolved from RK, AK, PRK, LASIK, interlace, epilasic, smile, contour vision, and again we have come back to advanced surface ablation. So PRK was more accurate than RK. It was able to treat myopia, hypermetropia, it was stable, but the problem was it was causing more pain, there was a delayed healing, there was a risk of scarring much more common in those days. Then came LASIK. There was a rapid recovery, wow factor, decreased risk of scarring, no pain, but some complications like flap striae, buttonholing, partial flap, debris epithelial ingrowth, DLK, late trauma, and ectasia were common in this condition also. Then came the femto. We have got much thinner flaps. There were fewer flap-related complications, but some problems like persistent photophobia, rainbow effect, higher DLK, late trauma, and ectasia were still there. Then came the smile. It is a good technique, but there is a lot of limitation at present. There is no hyperopia correction, customized treatment like topo-guided, wavefront-guided treatment not possible. Difficult in low power correction, bitoric, mixed astigmatism are difficult. Treatment is centered on the pupil. No cyclotorsion compensation. Little decentration on the femto will have no effect because it doesn't have refractive component, but a smile it will affect a lot. Then came the advanced surface ablation. There are some special indications where we can use advanced surface ablation, like in FFKC, if there is irregular astigmatism, if the cornea is thin, if there is night vision concerns like glare from glasses, pupil or flap, if there is anterior stromal opacities, if there is a person involved in the contact sports like hazardous duties, if there is a prior RK or AK, if you want to do wavefront treatment, remember if you may take a thick flap, all the wavefront things get disturbed. But if you're doing it on the top, you're getting the maximum correction. Then the patients like RD surgery, filtering blab, deep set eyes, was difficult to put a ring. Then you can combine it with C3R. So we have got various presentation, and PRK is supposed to be the minimal chances of ectasia there compared to all the things what we are doing at present. So these are the studies, I'll not go. But we can combine it with PR, we can combine CXL with PRK, that's again a big advantage. Basically it's a topoguided treatment and already we covered that we just treat the aberration part only in this. We don't treat the spherical or cylindrical, whatever is there. Our aim is not to treat the refractive correction. So we reduce the parameters and do the things, I'll not go detail. So why there was haze in earlier PRK cases? So we were doing more than 6 diopter correction, if we are trying to do hyperopic correction, if the ablation depth was more than 80 micron, a smaller diameter ablation, if we are doing a retreatment or the previous corneal surgery, these all led to corneal haze. The normal surgery was like this, local anesthetic drops. We are removing epithelium by Omail's brush or what alcohol assisted or the manual removal. When after removing epithelium, laser was applied and then came the mitomycin which changed the game at all. And we put the bandage contact lens, antibiotic lubricants. This is the usual PRK we were doing earlier. The complications which were common are the stomal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosion, which may cause significant discomfort, epitheliopathy. So how we can improve the results in advanced surface ablation, that's very, very important. Careful pre-operative checkup is again important. Blepharitis is there, we have to make the good lid hygiene, scrubs and antibiotics. If it's a dry eye, we have to use artificial tears, cyclosporin drops, ointment or puncture plugs. Dry eye is more common in middle-aged patient. We use tablet prednisolone just for 2 days, not for 1 week. Sorry, when operative, we have to use mitomycin, which was a game changer. We use chilled BSS. Proper fitting contact lens is again important. If you see any debris on the day 2 or 3, just change the contact lens, that's very important. Contact lens soaked in AccuVel or AccuSet is supposed to be reduce the pain. Of course, AccuVel is not available and we are using AccuSet. Then there are newer contact lenses are coming which are biodegradable. I think that will be again more beneficial. NSAID should not be used directly before putting contact lens and don't use too much. Mitomycin C is a potent antimicrobial that inhibits DNA, cellular RNA and protein synthesis. It blocks keratocytes activation, proliferation, myofibroblast differentiation and subepithelial collagen formation. So that's why it's result in stromal scarring. Again, we have to avoid overuse of topical anesthetic. Don't give any anesthetic. Oral steroid should be restricted to 2 days. We have got better painkillers now. Anti-seizure medication like gabapentin or pregabalin are very potent. Avoid aminoglycosides as they are corneotoxic. We have to improve the epithelial regeneration, doxycycline twice a day. If there is epithelial defect, avoid UV exposure. That's again very, very important. Normally what happens, we just say buy a UV goggles. That may not be perfect UV blocker. So it's the best if you can provide yourself, that's the best option. Sorry. Then nutrition supplement is always helpful. What has changed now? Why has come in the big way now? Because we have got the better techniques to remove the epithelium in a wavefront optimized way. So it's a smart surface technology from This is giving a very smooth surface, then streamlight from Alcon. So how the pattern has changed? Basically, this is the slide. You can see what we were doing earlier and what we are doing now. This is practically PTK is in neutral, it doesn't causing any change, and epithelium is totally removed. It's a totally one-step procedure, and that's why we have increased our limits. Normally, I am doing up to -10 spherical equivalent. You can correct myopic astigmatism. Hyperopia can be corrected up to +3. Even the astigmatism, mysticism. So practically, we are covering whole the range with advanced surface ablation now. This is a one step, no time lag. First epithelium removed, followed by refraction, optical zone selection, sorry, which corresponds to refractive correction, less myopic shift compared to standard PRK. There is an optimized epithelium removal. That's the crux of these newer software we got. So epi ablation zone autocally will be determined by laser based on the PRK ablation profile. There is an active eye tracking system throughout the entire process. So what are the advantages of transepithelial PRK as such? It accelerates healing by visual recovery by limiting minimum epithelium removal. There is less pain, reduced risk of haze by accelerating healing by smooth surface, better contour, by removing damaged cells and reducing thermal effect. All these add to reduce risk of haze. Thank you. The shortcoming, the flip side is that it accentuates the importance of epithelial mapping. You should have a OCT which has epithelial mapping capacity. It causes more heat. It's still not available with premium profiles, like you can't do customized treatment. It has a price tag, you have to use a card. So overall advantages of surface ablation is it's a gentle, no touch, no cut, no incision. It's a very safe, more biomechanical preservation of the cornea and stability. It's a stress-free, faster treatment in a single step. No effect on the posterior segment. That's again important. Excellent clinical outcomes. Reduces dry eye by leaving the nerves that produce tears intact. Can be combined with CXL, and it's a very economical. You don't have to use other femtosecond or microcotome with this one. It's still underutilized and have a great potential. Thank you very much.
Excellent talk, Dr. Arora. Very informative, and probably you have touched the future of ophthalmology. We should not go by the need of the patient for an early recovery, but comfort. He's going to get whole life with advanced surface ablation. Thank you.
Thank you very much. And with this, we come to the end of our this instruction course. And the message is very clear. Everything is there, even the microcotome, even the femtologic, even the smile, even the advanced surface ablation, and all should be there in a surgical armamentarium of a refractive surgeon. Thank you very much.